I think that's the end of the list. If I forgot you, go ahead and put your stuff in chat and we'll take a look at it there, but we'll go ahead and get started. Dee, take it away.
Okay, well, this morning we're going to talk about parental mental illness and issues related there to risk and safety. And so again, I invite you to, stop me if you have questions or comments, or you can put something in chat and I'll try to take a look and stop every few minutes. And so, of course, obviously this is a big subject. And so just going to cover some of the highlights here in a few minutes there. So it's common to talk about in child welfare. A lot of times scholars will talk about the big three kind of risk factors or issues related to safety, which are substance abuse, chronic mental illness, and domestic violence. And probably that's a little bit inaccurate in that those conditions are almost always associated with poverty. So it would actually be more accurate to just talk about the big four. That is substance abuse, parental mental illness, chronic mental illness, domestic violence, and poverty. And so it's the combination of these factors together, and they occur in different kind of ways and, in different kind of groups there. So we're going to talk about some of the common ones here today, and some of the issues related to case planning around particularly the chronically mentally ill group. So probably the single most common chronic mental illness that you find in the among child welfare parents is the combination of substance abuse and a mood disorder, usually depression, anxiety, PTSD, sometimes bipolar. So a couple of things to say about that. I mean, we're going to also talk about chronically mentally ill people who don't necessarily have a drug problem, but to talk about sort of the biggest group, and the group that we deal with most often is this group where mental illness is a co-occurring part of a co-occurring disorder there with drug and alcohol issues. And so a couple of things to say about parents that have this kind of presentation. I mean, they have this kind of combination of drug alcohol issues with a ongoing kind of a mood disorder. And the first one is that they're more difficult to treat. So just to start off with that, I mean, in the first place, probably among the dependency cases that you see that all of you are involved with, this is probably the co-occurring disorder thing is probably the rule rather than the exception. That is, most of the parents you deal with probably with kids in foster care probably who have a drug alcohol issue, or who probably it is in combination with the mental health issue most of the time, not all the time, but most of the time. So in the first place, that is going to make the parents increasingly difficult to help. And the main reason is because they are going to be very, very difficult to engage in the first place in any kind of treatment. And the part of the reason that is that co-occurring disorders among low-income people are a proxy for early trauma. So I want to say that again. A co-occurring disorder in low-income populations, the sort of folks that we encounter in child welfare, that is usually an indicator that there was trauma in their childhood, in their families of origin. And so very, very common to find histories of physical and or sexual abuse. And maybe when I did a presentation a few months ago, maybe I even sent you guys, I can't remember whether I sent Ryan this study from Madison, Wisconsin, from about, pretty old now. It came out in probably 2004 in Social Service Review. But anyway, that was a study of women with co-occurring disorders in Madison. And in that particular study, about, anywhere from 80 to 90% of the women had histories of both physical abuse and sexual abuse in childhood. And then as they got somewhat older, also histories of violence with intimate partners. And many of the women had been in prison and had suffered violence in prison at either at the hands of other inmates or guards, and so there was a And of course, they were very, very poor. And these were women who were receiving services through the public system there, that is publicly funded substance abuse services in Madison. So that's sort of the picture there. I mean, so the first thing is there's going to be a lot of difficulty then in engaging these folks in treatment. There's going to be a more than usual amount of resistance to that. And so when I train caseworkers on chronic neglect, this is definitely the presentation that you find in chronic neglect over and over again, is that the biggest challenge for child welfare people is just to get the parents to do anything at all of a positive nature about their problems. And even though they're a very needy group of people in all kind of ways, there is tends to be a very strong pushback to offers of help. And so the skills that are of paramount importance there are engagement skills. That is how to get people who present a lot of times as pretty hopeless, helpless, to believe enough in themselves and in their potential to actually enter treatment again. And a lot of course, the women in the pro have been through treatment before. They have either failed to complete it, been kicked out of treatment programs, or maybe they completed the program, but they relapsed anyway. The programs didn't help them in the past from their perspective. And a lot of times they're pretty resistant to doing anything further about their issues. But of course, it's of the utmost importance that they do make another effort here. And so there are going to be issues there around trust, issues around being able to establish a relationship enough with people to get them doing something and moving on their own behalf. And of course, a primary issue there, the co-occurring disorder from the mood disorder there, and the most common one is going to be depression. And I think that within child welfare, there just is a lot more interest and a lot more scholarly work, frankly, that's been done on drugs and alcohol than there has been done on depression, even though they're frequently found, of course, in combination with each other. And I think, of course, it's the underlying depression a lot of times that's driving the substance use. So one of the big issues there for parents, mostly women, who have this combination of issues is that even as they become clean and sober, if they do, or for periods of time that they do, it's not necessarily the case that they're going to be able to safely parent their kids, right? Why? Because the substance abuse is serving a function there. And the reason they're using it, it's helping them in various ways. So if they give up the use of drugs and alcohol, then the question is, well, what are they going to put in its place? And so just because people become clean and sober, that just may mean that they're even more depressed, or that the depression even has a greater impact on their ability to function there. And so there should be any automatic assumption that clean and sober in these cases where you have these kind of co-occurring disorders, there shouldn't be any kind of assumption that clean and sober means safe child. I mean, it may be, but that's something that has to be assessed and evaluated on a case-by-case basis. So before I go any further there and talk a little bit about depression treatment, let me just stop there and see if anyone has comment or question here. Any comments or questions about what I've said at the date? Okay, so a little bit about depression treatment, just real briefly. And there have been now literally hundreds of studies of depression treatment, both the wide range of antidepressants, the use of cognitive behavioral therapy, other kind of interpersonal psychotherapies with depression. And, to simplify this greatly, pretty much the message is very, very much the same. That is the treatments that are most commonly used today help anywhere from maybe 60% to 65%, close to 2/3, anywhere from 3/5 to 2/3 of people over a period of a few weeks or a couple of months there in terms of symptom relief. So of course that leaves a lot of folks who aren't, that leaves at least a third of people who aren't helped by these treatments, and either the antidepressants or cognitive behavioral therapy. There used to be an idea, and maybe there still is in some circles, that if you combine antidepressants, the use of antidepressants with CBT or some other form of therapy, that maybe you would get a marked bump in effectiveness rates. And it appears that there is a little bit of an increased effectiveness, but it isn't like a hugely major one. And so you still end up with just a lot of people who don't appear to be helped by, as far as the depression goes, by the treatments that we have available today. So the most interesting thing that has happened in the last couple of years, 2-3 years, in the era of depression treatment, is the increased use of psilocybin, of the psychedelic. And so now I think there's a lot of excitement among at least some group of folks in the medical community or therapists about the potential, which I think is, we still don't quite understand what the potential actually is. But it appears that some people who could not be helped by antidepressants or by talk therapy appear to be helped by the kind of experiences that they have on a psychedelic. And so now, I think it varies around the country, the extent to which the use of these drugs is legal in treatment, but I think it will increasingly be the case that they will be used. And then within the last week or two, I read an article in JAMA about the use of ketamine, which I didn't even understand what that was. So I read this study, which is an anesthetic. I mean, it's so a pain reliever kind of thing, which is now being used for the treatment of depression too. So I guess what I'm saying is that this is an area where there's constant experimentation, constant exploration around how to help, particularly the people who are very intractable to treatment. So the other thing to know about depression treatment is that there are people who are very hard to help with any drug or with any kind of interpersonal kind of a treatment. But at the same time, there are a lot of people, and I mean a very large group, that are helped by a placebo. And so in some of the studies, some of them unpublished of depression treatment, as many as anywhere from 1 in 3 to 1 in 2 people have symptom relief from just the mere use of a placebo in a controlled trial. And so that is why sometimes it's been hard for some drugs to demonstrate in trials, to demonstrate that they're actually effective, because the placebos themselves are so effective for anywhere from 1/3 to about 1/2 of people. And of course, the big advantage of the placebos is that they don't have the side effects that sometimes the antidepressants actually do have, and particularly the side effect of weight gain. And I think the underlying meaning to me is that a lot of people kind of just get over depression. That is, probably get over it without a placebo. I mean, it's just because it's one of those kind of mental health conditions that comes and goes. And for most people, it's fleeting, or at least it isn't a chronic condition that hangs on. But for some people, of course, it is. And part of the reason that it is because depression is the most common mental health symptom condition associated with trauma histories. So to say that again, despite all the talk and interest in PTSD, which is understandable and rational as well, the main effect of trauma over the life course is to make people more vulnerable to depression, to major depressive disorder. And I think the thing I said in maybe a previous talk is that having one episode of major depressive disorder makes you more vulnerable to having a second episode. Having a second episode makes you more vulnerable to having a third episode, and so forth, right? So it's not just that this is a chronically relapsing condition, which it is. It's that every time you have an episode, you're more likely to have another episode. I mean, whatever defenses are there in terms of immune systems are being weakened by the continued occurrence of these episodes. And sort of the difference between major depressive disorder and just your regular ongoing kind of, hey, I feel down, I feel sad, I have the blues. I mean, all of us familiar with that. Sort of the difference between having a bad cold and having a flu that can kill you. So they're both viruses, but one is life endangering, the other isn't. And for the most part, we just get over colds, right? We get over the flu, even when it's bad. So, but on the other hand, there's a group of people who don't, and those people are, highly likely to have trauma histories, which has a bunch of implications there that are sort of spelled out in the article that I mentioned on the women in Madison, and particularly the issue around power and control. And so the sort of the short version of this is that the more people's lives have been, a person's life has been affected by trauma, the more important it is that they have power and control over what happens to them now. And of course, so that leaves everyone, in a position to think about what's happening to people who are in a court system or who are being ordered to do X, Y, and Z, where a lot of their rights and they're being mandated to do all kind of different things. And that's just a lot of times with trauma victims, that's counterindicated in terms of the likelihood that treatment is going to work. But yet from the safety of kids, sometimes it's necessary, right? So even when people are in a court setting, even when there are mandates and so forth, all of us need to be thinking about, well, what kind of choices can we give people, even within this legal structure? And by the way, those same questions are important from the standpoint of kids as well. So even very little kids. So when kids have trauma histories, again, we need to, as we intervene and hopefully do things to help them out, we also need to be thinking about, well, what kind of choices can we give these kids? Even very, very young kids. And that goes, of course, even more so as kids get into the teen years and into young adulthood and so forth. So before I go on here and talk about some other issues here, let me just stop. See if you have comments or questions.
Hi, can I make a comment?
Yeah.
So I'm a big, big advocate for getting trauma-informed counseling for the kids I represent, and I see the benefits every time we make court reports on how that is beneficial, not only for the individuals caring for the child, but also the children themselves and the growth and development that they experience. I want to speak, though, that I am in a county where we lost our mental health provider, and we are just primarily limping along with just crisis services that even within our, that basically people have to be served outside of our county. And so my other point is this: when individuals are in these court systems, the pace and speed and clip of a court proceeding from the day you get the case and as they keep moving through the case is a whirlwind. And when you're up against lack of services, lack of providers, generational trauma, generational poverty, generational abuse, it is mind-blowingly frightening how the system is not set up to really address what would take years for some people to get through. And with depression, you're looking for some people, this can be, years. You can have hard depressive episodes that become the gauge of whether you're feeling blue or whether you are within a depressive chemical imbalance that is wiping you out. And I just feel like I just want to express those points. Thank you.
Now, so I agree with all that. And so, so part of the issues around around child welfare in this state, it very much has to do with issues around the mental health system as well. So, child welfare reform in this state can't just mean reform that applies to DCYF solely. I mean, there are all kind of issues around the mental health system here, and there always have been those issues ever since I've been here. And I came here in the late 1970s from a state that had better at least mental health services than this state has. So this state has for decades been especially delinquent at the policy level about funding mental health services for either adults or children. And now in recent years, sort of those chickens have come home to roost there. And there is more of a realization that there has to be an improvement here, a major league improvement, which is going to take, even if policymakers do the right thing. And in the last couple of years, they've started to do some of the right things. It's going to take a decade to make a dramatic difference here. That's just because you had decades of system-wide neglect here around the mental health system, even more so than around the child welfare system. And so in the meantime, that leaves all of us in kind of with a big dilemma here. I mean, what do you do? I mean, if you're in a place that literally doesn't have services for people and so forth. So this is why I think in the past, and particularly in relationship to kids, I just want to recommend again the Deborah Gray book, Nurturing Adoptions. That's just such a great book. I mean, she's a therapist in Bellevue. She has concrete suggestions that everyone can learn. In other words, this doesn't have to be carried out by therapists in a mental health center. It doesn't have to be done like that. And particularly the people who need those skills the most are the caregiver people, whether that's foster parents, adoptive parents, whether it's birth parents, whoever it is. But everyone can benefit from knowing what some of those skills are. And there are a lot of times they're very simple skills. They don't involve, you don't need a PhD to help people understand the value of slow breathing. For example, a way of calming down for people who have trauma history. So a lot of those skills are out there, and there's so many resources available now that weren't there in the past. And so I have, in the past, I've sent you guys resources and lists, and I think I probably mentioned the Deborah Gray book before, but to mention it again, and other stuff as well. I mean, the body keeps the score. By that book came out in 2014. That's just a tremendous summary of the sort of the status of thinking about trauma treatment when that book came out, which was now almost a decade ago. And there has been movement since that point in time, but that still is a great book. So all of us can, I guess what I'm saying, all of us can learn something about this. That doesn't necessarily require that we have mental health therapists at our beck and call, as great as that would be. And there has to be continued pressure here. I want to say this on the policymakers are only going to do the right thing under pressure. I mean, I know that from living in this state for decades. They're not going to do things just because it's a good idea or because some expert says it's a good idea. There's going to have to be public pressure here. And so then there has been in recent years on the mental health side of things. And so now there's starting to be some movement there, but we're starting at such a low point here. I guess that's what I'm saying here. Now, this state has made more enlightened investments in substance abuse treatment and in innovative programs in that area than it has made in mental health. And so you do have a brighter outlook there for the parents who have the co-occurring disorder thing. They're more likely to be able to access a program that actually knows something about co-occurring disorders than if it's the other way around. That is, what if you have a parent that has a mental health problem, but they don't have a drug problem? The kind of group that we're going to talk about here for a few minutes there, then it's much more difficult. And so what's the name of the author of Nurturing Adoptions? It's Deborah Gray, Gray, and she's also written a book called Attachment and Adoptions and a couple of other books that I highly recommend. And the reason I recommend them is they're so concrete. That is, they're focused on concrete skills that line up with the age and the developmental status of children. And that's why they're good. I mean, they're good from a theory standpoint too, but the value of them is in the potential ability to apply the ideas that are there. And because the ideas are very practical and concrete. And of course, with kids in the trauma area, the main idea is we have to help them be able to calm down. Unless they are able to come out of the meltdowns and be able to stop some of those meltdowns before they occur, they're not going to be able to stabilize in foster care. They're going to have a high rate of disruption from adoption, and they're not going to make it through school systems. So, so that's where the focus has got to be in the trauma-informed care. Concretely, what does that mean? Trauma-informed care. It means help in helping kids themselves to calm down, to self-regulate. And that's what's been compromised by their trauma histories. And by the way, that's true of the parents, why are the parents like this? The ones that we're dealing with in child welfare so often that have combinations of drug alcohol issues and mental health issues and domestic violence as well. That comes directly out of trauma histories. Okay, so one other thing I want to say about before I go on to this issue around people who have chronic mental illness, but not necessarily a drug and alcohol problem. Mental health problems, as I think all of you know, I mean, we tend to think about them in terms of categories like, I talk about mood disorders. That's kind of a category of mental health issues. But of course, there are also issues having to do with sometimes what are called axis 1 kind of disorder, issues that have more to do with delusions, that have more to do with hallucinations. There are folks in child welfare, some folks who have, not as many by any means, but there are some who have issues of that type. And we're going to talk about, and then there's the third group of people that have the personality disorders. And that's a distinct group of people, right? At least in terms of the thinking. Now, the issue here is that a lot of times chronic mental illness doesn't come in these neat, nice diagnostic packages. That is, a lot of people have combinations. That is, you can have more than one mood disorder. You can have, and it's common to have more than one. You can have depression and anxiety. That's very common. People who have trauma histories a lot of times have combinations of depression, anxiety, and PTSD. Also very, very common. But there are other kind of combinations as well. I mean, it's possible for people to have personality disorders and they are depressed. And so, what that means is there is a need for some kind of good quality, high quality assessments of people's mental health functioning, right? And a lot of times easier said than done in this state. But even in the absence of really good treatment, it really is helpful to have a diagnosis that's nuanced, that's thoughtful, that has really carefully considered the history of people. Always, you don't ever want to be sort of talking about people's sort of mental health issues and problems without being aware of their histories. I mean, I don't even know quite what that would mean exactly, but whatever it means, it isn't good. So one of the ways that you're going to know that you have a psychological or psychiatric evaluation that's competent is that it presents people's issues, their extreme mental health functioning in terms of a developmental history. How did they get to be like that? And that's something we need to understand about the adults, and we understand about the kids as well, kind of, right? So let me talk a little bit about people who have issues around they're schizophrenic, they're schizoid in some kind of way, and which concretely means that they have thought disorders of various types. And what that means in just concrete parlance is that they don't necessarily perceive reality the way that most of the rest of us do, right? At least part of the time here. And so, and particularly that group of folks, I mean, if they're in their 20s or 30s, 40s, of course, they're going to be on meds a lot of the time. And sometimes they're going to be on whole bunches of meds. And this is kind of to me, one of the shocking things that has happened about mental health treatment in this country over the years is that for the chronically mentally ill group of people, a lot of times it's come to mean something that's not much different than just medication management. That is, a lot of people who are chronically mentally ill aren't getting, it seems like to me, much of any help at all, except that they're going to a psychiatrist every month or a few months and they're getting a prescription for some kind of med. And the docs are kind of adjusting the meds that they're on. A lot of times they're adding meds without necessarily knowing the interactive effects of all of those meds, right? So that's the kind of the chronically mentally ill group. Now, what happens concretely, let's say some of those folks have kids. And sometimes they're very young children, and sometimes they're somewhat older. And so the thing you notice first about the chronically mentally ill group is that they're not mentally ill all of the time. That is, there are periods when they're doing better and periods when they're doing worse. And this is of particularly importance in the child welfare arena, when we're trying to assess kind of the risk of future harm or issues related to safety. And so even someone who's untreated, who has a chronic mental illness, there are going to be periods where just in the normal course of things, without any treatment at all or without any drugs at all, they're just going to be doing better for whatever reason. And then there are going to be times when they're doing a lot worse, when they seem to crash. And there's going to be a cycle here. And sometimes the cycle is controlled by their desire to get off of those meds. And why do they want to get off of those meds? Because those meds are ruining their lives from their perspective. I mean, they're suppressing symptoms, and they're suppressing delusions or thought disorders of the sort that in past decades might have put them in an institution. But they're doing it at the cost of their well-being from the perspective of the person taking the med. And so a lot of the chronically mentally ill folks we deal with, they're trying to get off those meds from time to time. But when they do, that's very difficult to do. Very, very hard. And so sometimes, of course, what happens is that there will be a mental health crisis that comes out of a person's attempt to get off the meds. And they just can't do it. And then they end up, or they can't do it easily. And then they end up in a sort of a mental health crisis. And whatever kind of capacity to parent they had before, they lose whatever their capacity is, and they're in a crisis again, right? So a couple of thoughts here about this cycle. When you're dealing with chronically mentally ill kids and you're dealing with them in relation to parenting duties, you always want to know, one, I've already said, you always want to know the history of how they got there. And if you don't know that, you just have a big dark spot in your understanding of the person, and you need to correct that in whatever way you can. So that's the first thing, right? You need to know something about their histories, and both from their perspective and from the perspective of experts in the community, both perspectives, right? But the second thing is you need to know, what is their maximum capacity? What can they do when they're functioning at their very best? When their mental illness, whatever it is not evident at the time. What are they able to do at best in relationship to their children and to their child or to their children? So that is, what's their best level of functioning? And then you also want to know, well, what's their worst level of functioning? I mean, when they're really in the pits. I mean, when they're having the delusional episode, or when they're hearing voices, or they've just been hospitalized, or they're incoherent. I mean, so you want to know, at the very worst, what is the person like? And you need to have the full range of that understanding. Because if you interact with someone at a time when they're doing kind of well, you can minimize the significance of their mental illness. If you only interact with someone when they're in the darkest place that they can possibly be in their mental functioning, you don't really understand their potential at all, right? You may think they don't have any potential to be a better parent or a more functional person, and both of those views are false, right? So you need to have a sort of a range of views here. But from the standpoint of safety planning for kids, you have to think about safety planning in terms of what's the worst thing that can happen to kids when the chronically mentally ill person is in the depths of their mental illness. What's the worst thing that can happen then? And you have to have some plan to control for that in some way. So I'm going to say that again. You have to have some plan to control for that in a way. So there's going to be a periodic thing here, both in terms of treatment for substance abuse and for mental illness. The treatment, even when there is very good treatment, it's going to be an up and down thing. It isn't going to be, wow, the person is just making fantastic strides and they just get better and better. And no, it isn't like that. You know, there are peaks and valleys there in terms of a therapeutic progress, right? And you need to be attuned to that. And so do people in the child welfare system, with a plan for what's going to happen when this person crashes again, because those are chronically relapsing conditions. The likelihood is that even if they stay on the drugs, which they probably are not going to do on a 100% basis, even when they do, they're still going to have those dark episodes. And so what's the safety plan for them then? So generally speaking, that is going to have to be some kind of a safety network of people. So I'm going to say this again. There are some, so there's no, to me, true generalization that you can say about all mentally ill people, that they either can parent or they can, or, you know, anything you hear. You know, I hear people say things like from time to time, well, mentally ill people aren't really more dangerous than the rest of us. You know, when I hear stuff like that, I just disregard. I mean, that's well-meaning. Some mental health advocates say stuff like that, but it doesn't mean anything. It's not based on nothing. You know, unless you know the type of mental illness the person has, right? So you're not going to say that about a paranoid schizophrenic if you know anything. You're not going to say something about a bipolar person who has explosive issues. You're not going to say they don't have a potential for violence if you know anything. And you never want to plan for people in terms of a gross category like they're mentally ill. Like we can make a plan just by putting a label like that on someone. You know, you can't do that in a rational kind of a way. So we need to have a specific understanding of what their mental illness is and of what their potential is, both negative and positive, I've already said here. So there's going to have to be a social network for them to parent, and some of them can and some can't. And let me talk about right off the bat some of the mentally ill people who can't parent. Okay, so here are some of the indicators that a person cannot parent. They cannot maintain a parenting structure at all, even for very young children. And a parenting structure means a way of getting kids' basic needs met on a daily basis. Something as simple as how you get kids up in the morning, how you get them fed, off to school, bathed, played with, fed at night, read to, cleaned up, put to bed, and so forth. Parents of very young children have to be able to do that on a very consistent basis. And so that's always a question around anyone who has impairments of any type, is are they going to be able to do that? Secondly is, and this is of super importance when you're talking about the chronically mentally ill group of people, can they accept help from other people? Can they form relationships enough and engage, not with everyone, but with someone? Can they form a relationship with someone so that they trust the person enough that that person can play a role in their life and help them? Because one of the things you know about chronically mentally ill parent, unless they have help, they cannot do it. I want to say this again. If you have a mentally ill person who can't form relationships with anyone because of the nature of their mental illness, and I'm going to talk about a case like this in just a minute that I just dealt with in another state. If you have someone like that, they're not going to be able to safely parent kids. So they're going to have to be able to form relationship with someone. So you want, before that is, therefore, you close cases and you close out child welfare cases or whatever, there needs to be a safety network around chronically mentally ill people. And sometimes a safety network just means some people who care about them. And that can be family members, and it could be a minister, it could be, people in the mental health community, it could be a lot of different people, it could just be friends, but it's got to be someone. And a lot of times it's got to be more than someone, right? So you're going to have someone that, that is involved enough with the person and their kids, their kids on a regular basis, that they sort of know how the person is doing and that they can check in with them on a regular kind of basis, and they can give them encouragement and help as kind of needed there, right? So there used to be, in years past, when we had somewhat better mental health services, and even for the most part we have today, some public mental health centers had case managers for chronically mentally ill people who would deal with them, help them over a period of, stay involved with them over a period of years, not just weeks or months, but years, right? Because that's what some chronically mentally ill people need and require in order for them to be functional at all, right? And so that has to be sort of a goal, a case planning goal in the cases that you deal with, and in the cases that child welfare deals with where there's never a court filing. There still needs to be an effort to bring such a group together around a person. It doesn't have to be a super large group, but and again, you start off with family members. Now, over the years, I have done training for child welfare staff on these issues. And so I talk about chronically mentally ill people, and sometimes I pose to them a question, and I give them a scenario of a little boy who's 6 or 7, whose mother has had a sort of a psychotic break, and she's been hospitalized, and he's staying briefly with an aunt or an uncle or someone like that, and And he's a nice little boy. I mean, he loves his mom, but at the same time, he's little, and so he isn't going to be able to take care of himself on his own. So the question I pose to the group is, if this happened in your family, and most of us deal with family members who have issues with drug and alcohol or with mental illness or other kind of issues as well. If it happened in your family, would your family need the child welfare system to intervene to take care of this? So I've posed this question to many groups of caseworkers over the years, and in recent years. And so let me tell you that most caseworkers in DCYF, the majority, say no, their families are functional enough and they would be able to deal with this without a child welfare involvement. And so I take them at their word. I mean, they work in child welfare. And so a lot of times what you kind of do is you want to bring people together around a family through family team meetings or in some other kind of way. And you want to figure out whether this family can handle this without there necessarily being a dependency action or the kid, being under the auspices of a court or something. Now, let me just say personally, I grew up in a family where for years and years, we had these kind of issues in our family. And for the most part, for several years, our family handled it without any child welfare involvement. I don't even know there was a child welfare system, but they weren't evident to us. And the family handled it, maybe not always in the perfect way, but adequately. And then there got to be a period over the years because, of course, chemical dependency, its nature is, people tend to deteriorate with that over time, a lot of the time. There was a time when our family couldn't handle it on our own. There was years when we could, and then there were years when we couldn't. And when we couldn't, there was still no child welfare system in evidence there, right? So one of the things that child welfare people have to do, and that people in your role have to do too, is to figure out whether extended family systems can handle this. And that concretely means, is there someone in that system who's not a drug addict, who holds a job, who's a responsible person, who's raised kids of their own, who's interested in the family, and who isn't obnoxious in the way that they deal with people within their family? Is there someone like that who can pull this group together and make sure it functions on behalf of kids of the chronically mentally ill person, right? Now sometimes there is such a person in a family, but they will say, because of our dealings with this family we can't do it without legal structure. We're just going to have legal structure to manage, because otherwise they'll just come get the kids. Just right out of the blue. Kids could be there, living there a year, and a mother who's had a mental illness could show up and just take the kids. Right? So sometimes families will say, we need legal structure in order to manage this. And when they do say that, you should take them at their word. And in those instances, a dependency should never be dismissed until there is an assurance there's going to be a guardianship. There's going to be a transfer of legal custody there. And sometimes there doesn't necessarily even need to be a dependency in the first place. You can just go directly to the guardianship. So there's going to need to be, and family members know the answer to this question. They can handle the thing without legal structure, or they can't. And then in some instances, sometimes just because of proximity or distance or so forth, people are not going to be able to do that. And then the child welfare system is going to have to be involved. And then you have real issues here, because child welfare systems, particularly when there isn't court structure, they just have a lot of trouble in maintaining useful kind of contacts with families over a long period of time. And whether that's chronic mental illness or whether it's developmental delay, with parents who have low IQs or so forth, or the drug and alcohol group, child welfare agencies just have a lot of difficulty in maintaining and some of those families are going to need that kind of constant kind of involvement and over a period of time. And a lot of times you just can't count on it if there's been a reunification that is going to be the child welfare system. So let me stop here. Kimberly says this issue for kids devolving medication management appears to be, yes, and not just here, all over the country here. So this just gets me started on one of my, and I'm not going to get involved in a rant here, but just to say that I have written about this subject at length in sounding board commentaries. One time about 3-4 years ago, I did 3 or 4, excessive commentaries on the misuse of psychotropic meds for kids. And to me, this is one of the most outrageous, scandalous things that's happened in child welfare around the country in the last 20 years. It's to manage kids through the meds. And with knowing very, very little about the interactive effects of those meds. And just, in my opinion, with just disastrous effects on the well-being of children in many, many instances. And just one drug added on top of another drug to add on top of another drug, and just a very, very shocking kind of thing. And and by the way, there are just tremendous books on this subject. And so I've written commentaries on this, and which I name the books and the references, and I can send that to Ryan, and he can send it to you as well there. Okay, any other comment or so forth first here about, before I go on here? Okay, so I say a little bit more here about kids who grow up with chronically mentally ill parents. And here, I guess the first thing I want to say is that there's no way to generalize around what the effects of that is going to be on kids, other than there are going to be effects. And so one of the things you want to know, whether you're a caseworker in child welfare, whether you're a COS, is, well, if a kid is growing up with a chronically mentally ill person, what is the effect then? And by effect, I mean, what is the developmental effect of that? And what is the effect on the emotional well-being of the kids involved? And so, of course, kids have various and sundry strategies here that, well, you know, all of us are kind of familiar with. So you have sibling groups. A lot of times, of course, there will be a parentified kid within the sibling group. And that's true in drug alcohol, it's true in mental health, and sometimes it's even true in the DV cases as well here, right? So you want to know how kids have coped. So I guess what I'm saying is that when you talk about issues related to risk and safety, you also want to be thinking about issues related to the well-being and to the developmental status of kids. And again, the need for some kind of high quality assessment there is very, very, very important. It's not, and again, it's not just a matter of making sure that kids are physically safe in the short run. You know, I think all of you probably know that the state law is going to go into effect on July 1 that limits the sort of the interest of courts in the involuntary removal of kids to their immediate physical safety. You know, that is say this mildly, a very bad law, but it's going to become law. Nevertheless, it doesn't mean that people who work with kids should limit their concerns to just this issue around whether kids are physically safe. We also want to know about their emotional status, their emotional well-being, around issues around the cumulative harm. So a lot of what happens to kids in families with drug and alcohol, or with mental health issues, or with violence issues, is that they're being harmed cumulatively, gradually, steadily, daily, over a period of weeks, months, or years. That's what's actually going on. That cannot be reduced to the risk of imminent physical harm. And so to have a legal system that's only going to look at this narrow issue around child safety, imminent physical harm, and we're going to ignore all these other harms that have to do with growing up in these chronic families, wow, that's just a mind-boggling, I don't know, whatever I would say here would be probably a moderate language, and maybe better that I just do not say it. But I mean, that's the issue that all of us who work in child welfare in this state, and I mean in the system, and all of you and everyone who works around the system, that's going to be a major predominant issue in the next few years because of the passage of this law. So it's one thing, for example, to say about child safety that for the purposes of removal, we're only going to consider imminent physical harm. But that's not an adequate view of child safety. I mean, that may be a standard for removal, but it's not an adequate view of child safety. So you got to have a better idea than that in order to function as a competent person in in or around kids in the child welfare system. So short version, we want to know how kids have coped with growing up with a chronically mentally ill person. And then they might have, and sometimes they're going to be very enmeshed with a person. Sometimes they're going to be parentified. They can be actually taking care of the parent, or they can be at the point by the time they're 7, 8, 9, or 10, where they just want out of that situation, where they're just fed up, or where they're actually frightened of what might happen to them during a breakdown or something like that. So again, that's something that cannot be determined beforehand. That's something that we really have to get to know kids really well in order to be able to assess and determine. So, and that's of great importance in case planning. So if you end up with a kid who's 7, 8, 9, 10 years old, and they've grown up with a chronically mentally ill parent, and that kid wants out, you get them out. I mean, to the extent that you can. I mean, sometimes you're going to be limited by, legal parameters, but at other times, you do whatever you can. And that doesn't always mean that they have to be involuntarily removed by a CPS worker. It means sometimes they can go to the other parent. They can go to a relative, a grandparent, someone like that, who's actually a safer person for them. At other times, it would be disastrous from an emotional standpoint to remove a child of a mentally ill parent from that parent, because they are so connected to that parent. And in those instances where that's true, then we have to do everything possible to make it a safe a way for that parent to maintain custody of that child to the extent that we can within our resources, right? And I think by the time that kids get to be of school age, they have a lot of times a pretty good line on that, pretty good idea of what they want, what their interest is, even before they're 10 years old, 6, 7, 8, 9, 10. So let me stop here, and we're kind of run out of time here, and see if you have comments or questions here.
This is Pauline out of King County. I'm wondering what tips you may have as we're facing this upcoming law and going into court to better advocate for our kids. I know that that's a big ask, but it's just frightening to consider how we're supposed to show impact on children if physical safety is just going to be the sole or the primary focus.
Yeah, this is a big subject, obviously, and I think maybe what we can do is, let's just say that I'll talk about the whole entire subject this coming month. We'll just deal with issues surrounding the law, and we'll just take an hour to discuss the ins and outs of it, because this is a complex subject. We don't exactly know, of course, at this point, we're dealing with intuition, we're dealing with concerns, with anxieties. To a certain extent, I'm dealing with information that I've gotten from the Ombuds's office where the Ombudsman has already raised alarm about this subject. But so let's just say that next month we'll talk about this legislation and issues related to your role and to the role of caseworkers within the system as well, because there's going to have to be some strategies here. And a lot of the issues here have to do not just with caseworkers, they have to do with courts. They have to do with specific interpretation that courts are going to make. And it's not given what that law exactly explicitly is going to mean in terms of the kind of information that courts receive and that caseworkers have relative to families. So let's come back this coming week and this coming month, and we'll just discuss that at length here, right? So I think the last thing I want to do here, just real briefly, is I want to tell you a little bit about a case that I just dealt with in Minnesota. I helped a group there called Safe Passage do a study of 88 child deaths in Minnesota from 2014 to 2022. So over a period of 8 years. And so a lot of these deaths were shocking, to say the least. And so just to give you an example of how shocking, 14 of the deaths had elements of torture in them. And some of those torture cases happened in kinship families. 7 of those kids died in kinship families. from combinations a lot of times of abuse and torture. So this was a really, in many ways, a really shocking study, and a lot of cases with really extreme histories of drug, alcohol, mental illness, DV, and with a child welfare system that was pretty dedicated to just not seeing it, just to explaining it away, dismissing it, denying it. And the courts very, very involved in that. Not just the child welfare agencies in Minnesota, the courts very, very implicated in that. Well, so the case that I just dealt with in terms of a TV station in Minnesota called KARE 11, and I sent Ryan the story about this. It had to do with a 6-year-old kid whose mentally ill mother killed him, if you can believe this, with a shotgun blast to the head 10 days after the dependency. It's called something different. It's called CHIPS in that state. But what we call dependency, 10 days after that case was dismissed, the mother killed him with a shotgun blast. And the kid had been in care for about, at that point, almost 18 months. She was a mentally ill person who had a very unusual combination of mental health problems. She had a paranoid personality disorder, which I'll explain here in a minute, which affected everything about her interactions with people, which meant she couldn't form a positive relationship with anyone. That's what it concretely kind of meant. But periodically, she also had drug issues, and periodically she would have breakdowns, and she would have delusions, and there would be suicidal ideation, and she would go into hospitals, and then she would come out, and she was pretty much in denial that she had either a drug problem or a mental health problem that needed to be treated. All of the mental health, so now they have this child who's 5 at the time, for the most part. They have this kid in foster care. They have a plan where the only thing that relates to her mental health treatment is medication management. So nothing else is happening there around her, and nothing changes in her mental health condition over that 16-month period of time. She begins counseling at some point with a couple of people. She continues it for a little while. She never follows through on anything at all. The only thing that they had to address the drug issues was periodic drug testing. This was their version of drug treatment, drug testing. She ended up alienating the people at the drug testing center, and they cut her off. They refused to let her come in there anymore. So basically, she has chemical dependency issues and mental health issues that aren't being treated really at all. And then she interacts with people sort of in this way. She's constantly accusatory. Whatever they do, she's very unhappy with it. If she constantly asks them when she's going to get her kid back. If she doesn't like the answer, she asks them the question again and again and again and again. And she does whatever she can to undermine the child's relationship with a father. I guess the idea I'm trying to get across here is that she was able to get her kid back while she did absolutely nothing relative to either her drug positive, nothing positive, relative to her drug, alcohol, or to her mental health condition. And yet after 15 months, they gave the kid back within a year in what was called a trial placement episode, after she had been eliminated or thrown out of the drug treatment facility for being just an obnoxious person. So, and she did that by just being totally persistent with the people, particularly the caseworker, but also the guardian ad litem, just being constantly accusatory about why they were being so unfair to her, why they were not acknowledging the progress she had made and so forth, when she actually wasn't doing anything at all. And because she just kept at it, she was so incredibly persistent, they actually ended up not only giving the kid back, but they ended up dismissing the dependency after saying that there's no way she can ever meet this child's needs. We understand that, but that's not our goal to make sure she does that. We're only interested in child safety. That's the way they justified the dismissal of dependency there. 10 days after that, she kills the kid with a shotgun. Okay, reasonably speaking, they could not have foreseen, in my opinion, that she would do the act that she did in terms of murdering the kid. At the same time, it was obvious that she would never be able to parent that kid because, again, she was adequately parent the kid because she was a mentally ill person who could not ever form a relationship with a helping person because of her personality disorder. She constantly saw hostile intentions and motives in everyone that she dealt with. That's what it means to have a personality disorder of that type. And so she had no positive relationships that she could depend on. And so once she got the kid back, she started to sever all the services, all the ties the kid had to anyone. She quit sending the kid to school regularly. She made up excuses around the kid having COVID over and over and over again. She wanted to take the kid to Disneyland. She just, whatever she could do to sever the kid's connections with everyone else in the community, that's what she did. And yet she did that right in front of and in relationship to the caseworker and the guardian ad litem, and they still moved to dismiss the dependency and to give the kid back and to maintain that placement, right? That's what I mean when you're dealing with an unreasonable and super overly narrow standard of child safety. And they even said at the time, our business is not child well-being. Our business is not to assure that this child has his needs met. Our business is not how well he's emotionally coping, and he was not coping well at all in the school environment. He was hitting other kids. He had sleep problems. The child protection system didn't feel that that was any of their business. And apparently the courts agreed with them. And then you end up with this, totally disastrous result after person just said that this person would never be able to adequately parent this child. And by the way, she did have a long history of chronic neglect of his medical ailments there. So anyway, so I just put that case out there as kind of a cautionary kind of thing, right? Because it had to do with sort of the standards of decision making. I mean, they were well informed about this mother's functioning. They had a lot of interaction with her. They knew what she was like. They knew the kid wasn't doing well. They knew she was trying to cut off his relationship with his father. They knew she could not accept anyone that would have any role in her life or in her child's life. And yet they ignored all that. And they went ahead and gave the kid back anyway, right? So it's just something to mull over here just a little bit as we anticipate the implementation of this new law, right? I've mentioned a couple of things here in terms of resources that not today, but Monday, I will send Ryan and we can send you, and and then next month we'll talk about the law, and if I can think of something else in the meantime to send you, I will there. So thank you.
Thanks, Dee.
That's right.
Okay.